Welcome back, everyone. This is going to be the third video of the pharmacodynamics and drug tolerance PowerPoint slide set. We just introduced what is tolerance versus sensitization in the last video. So now we're going to talk about the forms of tolerance and how it works, and how we'll be talking about it in terms of pharmacodynamics in this course. So first we've got the forms of tolerance. We're going to start with metabolic tolerance. So this is pretty much how the drug gets out of our system. So over time, then we create more enzymes to break down particular drugs, which then increases the metabolism of the drug. So the drug gets out of our system quicker. This decreases that bioavailability of the drug, meaning you need more of the drug in order to get the same effects. We then have pharmacodynamic tolerance, so changes in the cell function in response to the drugs. This is where some receptors will down-regulate, results in saturation and diminished effects. Pretty much because we get so much effects of this, and the drug's being used so much, then the body's like, well, I guess we don't need these endogenous ligands and the receptors for it, so it changes in saturation. And then behavioral tolerance. Behavioral tolerance is the one that you probably heard about most in other psychology courses, again, especially intro psych. This is context-specific tolerance. This involves both habituation and conditioning learning. This is what can be very dangerous when talking about withdrawal or overdose, is behavioral drug tolerance. So this is demonstrated by tolerance in a familiar environment, but the tolerance is not seen in novel environments. Now, habituation can be likened to the first time having blood drawn or donating blood. With subsequent trials, the needle seems less and less painful. Even though your pain threshold is unchanged, it's just really, you're just more used to it. And that kind of happens with behavioral drug tolerance as well. And then, of course, we've got that conditioning going on, where we see in familiar but not novel environments. Behavioral tolerances can be demonstrated in both humans and animal models. So we see the changes in our physiology due to tolerance and really from that conditioning. So here, this is a graph of showing hypothermia in response to morphine injections in a normal physiological response in rats. So on the x-axis, we have the time since morphine injection. On the y-axis, we have body temperature, okay? So what we are looking at is after 10 days of the rats always getting an IV of morphine, rats were tested in either the same condition, the blue line, same environment that they first got morphine, or in a novel environment. So that would be the red line. And then we see the physiological response to an identical dose of morphine, okay? And we're looking at behavioral tolerance, okay? So this is hyperthermia, okay? So that means that the body is getting warmer, not colder, but warmer. So what we see is in the same environment, okay, the animals that are in the same environment are kind of predicting the morphine to come, and increases its body temperature before the morphine has even been injected, because the body's in that environment and is like, oh, this is going to happen. Whereas when the animals are in a different environment, then they don't have that preparedness. They keep their body at normal body temperature and then get injected. So there's an increase in body temperature anyways because the morphine has now been injected. But what we see is when the animals in the same environment they kind of are like, oh, I'm in this environment, my body temperature is going to go up, so the body temperature is going to preemptively start to go up. But then this animal has behavioral tolerance, which means the body is going to be like, okay, well, the temperature of my body is going to go up, but what I can do is actually prevent it from going up too much. Okay, so that's why this blue line is more flat than the red line. Okay, so one, it predicted it's going to go up, so it's going to start to increase before the drug injection, and then it is going to have tolerance where that drug effect of an increased body temperature isn't going to be as dramatic. Okay, it doesn't go away, but it's not as dramatic. Drug dependence is different than tolerance. Okay, you can have both, or you can have just one. Drug tolerance can occur rapidly, or it can occur slowly. It can be transiently or persistently. Whereas drug dependence is really that need for the drug. Okay, tolerance is just that changes in the drug effects. Drug dependence is you need the drug. This results from tolerance mechanisms, and it's considered a key component in drug addictions. Okay, so dependence tends to lead to drug addictions. Most significantly, this is influenced by those pharmacodynamic mechanisms because we have a requirement of the drug use in order to maintain that normal function. Now remember, drug tolerance does not always lead to drug dependence, and drug dependence does not always lead to addiction, okay? You can stop at any point along there. You can have dependence without tolerance, etc., okay? You can have either a psychological or physiological dependence. Both are possible. You can have both or just one. So how do we develop dependence then? A very classic model of dependence was shown in 1943 by Himmelsbach, and this was used opiates to show how dependence was created. So tolerance to opiates is proposed to develop as a result of compensatory mechanisms to restore homeostasis, okay? So remember, homeostasis is like resting state. So here you can just see we have homeostasis. You give an injection of an opioid. It obviously disturbs the homeostasis. What your brain does is it then changes in physiology, behavior to get your body back to homeostasis, okay? Now, your body changes so much that after time, when you stop taking the drug, it now disturbs your homeostasis because your body is still doing those compensatory mechanisms, okay? So acute administration will disrupt homeostasis but won't lead to compensatory mechanisms, but chronic use will. And that's where we see those repeated administrations. And withdrawal will also then lead to that disturbed homeostasis. And it's these disturbed homeostasis as a result of compensatory mechanisms that thought to be involved in the craving and dependence of the drugs and also addiction. Okay, so it's that drive to consume drugs in order to maintain that homeostasis and avoid the withdrawal symptoms. There's multiple demonstrations of dependence used in research models. We do a lot of this stuff in animals because it's quick and easy. And then we can study what's happening physiologically. Some in vitro studies have demonstrated the cellular effects of morphine, which is an opioid. So acute morphine treatment decreases cellular camp. Okay? With chronic exposure, so lots of morphine over a 48-hour period, then camp levels will actually normalize back to homeostasis. And so when you first get morphine, it decreases your camp. After a long period of having morphine, though, your camp levels get back up, okay, back up to normal. So the steady state camp levels are maintained in the presence of morphine, and then we get into withdrawal when morphine is removed, okay? Now, I mentioned before that opioid receptors are G-coupled protein receptors, and this is why we get these changes in camp levels. So at a cellular level, we can demonstrate the effects of morphine that corresponds to acute intoxication, the development of tolerance and dependence of morphine, and then we can also see withdrawal effects. And this all supports those studies by Himmelsbach. Now, what's happening during addictions? There's different classifications that use dependence as the key describer of addictions. So the DSM says it's a substance abuse disorder. Dependence is based on physiological drug responses for this addiction. There's some confusion that arises in distinguishing from normal and problematic dependences. So especially with pain management drugs, some people are in chronic pain and need these drugs to feel normal. So they are dependent on it, but are they addicted? And that can be a gray area. Some people, their pain is gone, but they still have a dependence on opioids to feel normal every day. So then that's where it would be an addiction. So that's where it's like, well, if they stop taking the drug, then we can see, do they still have the pain? But they're going to have to go through withdrawal, and it's a whole big thing, and it's very hard. Now, addiction may be better defined as a compulsive drug-seeking behavior. And that's because this fits into the idea of an impulse control disorder. Okay, so they need the drug. They compulsively need to go get it. So this relates more to like OCD. You have to do this in order for whatever. All of this, defining addiction, how to define it medically, because it is, it's a medical disorder. It's all confounded by societal norms and stigmatization. People tend to view addicts in a negative light. They view addicts as like it's their choice, that kind of thing. And a lot of people in society don't view it as the medical disorder that it is. So the other things you have to then talk about with drugs, of course, is intoxication. So this is just the clinically significant problematic behavioral and psychological changes associated with substance intake. So it's really when you take a drug for the non-therapeutic things. It's kind of like when you drink alcohol, people say, oh, they're intoxicated, right? Well, you can take anything else and also be intoxicated. So not all intoxication is considered problematic. There's no applicability of intoxication category to tobacco, even though there is a category in the DSM-5 for caffeine intoxication. Okay, so this is another kind of gray area of what exactly is intoxication. It's defined as problematic behaviors, but then there's some drugs that we say people have intoxication that don't have problematic behaviors. Okay, now alcohol, there are some problematic behaviors that come with intoxication. But some common disturbances are listed here. You'll see wakefulness, attention, judgment, hello alcohol, psychomotor behavior, interpersonal behavior, that kind of thing. A lot of this has to do with inhibition. Okay. Now there is differences in acute and chronic intoxication. So sometimes you just have a drink every now and then, you'll have different intoxication than for if you were to then start drinking every day, okay? Your intoxication will be different, okay? And a great example would be with cocaine, acutely taken, it produces gregarious behaviors, but with chronic use, it results in social withdrawal, so kind of the opposite. So withdrawal then from a drug is really just a substance-specific problematic behavioral change resulting from discontinued use. There are physiological and psychological changes that are occurring during withdrawal. There are cognitive changes specifically. It can cause significantly increased distress or impairment of social or occupational behaviors, and it's often associated with the urge to re-administer or reuse drugs, and so it can be very difficult to make it through withdrawal to being what we would call sober. There is this gateway hypothesis. It is, however, incompatible with biological theories of addictive behaviors, as what they call staging would imply a unique biochemical mechanism for each drug, or some sort of persistent change to the central nervous system that would result from drug use. And it doesn't address the underlying risks or vulnerabilities to addiction that promotes stigmatization and victim blaming. It's also very subject to the observer bias. So hard drug use is seen to be preceded by soft or illicit use. So saying marijuana is the gateway drug. It's not. Guys, it's just not. Okay? That doesn't work. A lot of people, they'll start here and then do soft and then hard. But a lot of people will just go straight hard or not. Or do cannabis and not ever go to hard. It doesn't make sense. Some people do cocaine but they don't drink alcohol. It's not real, guys. Cool. Okay, common liability. Drug use initiation is necessary, but not sufficient for development of a substance use disorder. Okay, so initiation does not account for risk of addictive behavior. So some people just have addictive behaviors. Okay, some people are just more susceptible for development of a dependence or an addiction than others. Disinhibition is commonly kind of a thing, predictive risk of substance abuse. So predisposition to impulsivity, hyperactivity, and antisocial behaviors. So regardless of the substance. It could be coffee, it could be cocaine, it could be alcohol. We don't know. It's really just anything. So some people just have a predisposition to it, and there's really nothing they can do. There's a high correlation of genetic risk for various substances. So we see this with alcoholism. There is a high correlation with genetic risk, but again, it's not causation. There's common neurobiology of multiple substances. So if you're had an addiction to one substance, it's most likely that you will develop a substance abuse problem to another one. It does explain the conserved risk for development of non-substance addictions. So you can become addicted to other things. A lot of times people, they'll try to quit smoking and start chewing gum, and then they actually become addicted to chewing gum. Okay, so that would be a non-substance addiction. So that is it for pharmacodynamics and tolerance. I have some summary slides that you guys can look at if you want just a quick refresher. So that is it for today, and we will start our first drug on Wednesday.